my
Okay,
screen?
very good, very good, very
Very
good.
good. Thank you so much. So I will just discuss some emerging risk factors for stroke. I know many of you will treat stroke in your clinical practice, and we know the common ones, but there are some which we may forget. So I thought I'll share some of these with you, which are now becoming more and more important. I will discuss the A to Z of the common risk factors. There are some that are emerging that start with I, U, and X, which I'll share with you before making some concluding remarks. We know stroke is a major cause of death and disability in most of the world, including Asia Pacific and in Vietnam. We also know some things we cannot change that raises stroke risk: being older, being a male, having a young family member with stroke, genetics like CADASIL, in ethnicity like American blacks, all have a high risk factor for stroke, and we cannot change these risk factors. But there are some very modifiable ones: high blood pressure, diabetes, hyperlipidemia, atrial fibrillation, a previous stroke, and smoking. We all know these, and we all do our best to modify them. But this is not the only risk factor we can treat. Here is the A to Z of all the important risk factors: atrial fibrillation, hypertension, cigarette smoking, diabetes, too much alcohol, being overweight, genetics, including CADASIL, and other genetic risk factors, young stroke, hormones, contraceptive pills, and hormone reduction therapy. I'll discuss this secret in a few minutes. Taking illicit drugs such as cocaine, carotid stenosis can raise stroke risk, hyperlipidemia, including Lp(a), migraine, especially migraine with aura, and in those who smoke, being overweight or underweight, sleep apnea, procoagulant states, protein C, protein S, homocystinemia, cardiac disease, including rheumatic heart disease, vasculitis. Sickle cell can also damage the brain vessels and cause stroke. We know previous TIA and stroke before. I'll discuss U shortly. Vascular disease in the legs also raises stroke risk. Getting older, like me, is one. I'm not as young as Dr. Hung, as you can see, always looking young forever. The X factor, being a male and having a very sedentary life with no exercise. So let me now discuss the I and the U and the X, because everything else you already know. I stands for infections, inflammation. These can cause stroke directly. Infective endocarditis can cause infected thrombus to go to the brain. Infections of the meninges, tuberculosis, cryptococcosis, and other infections of the meningitis can cause occlusion of small arteries in the brain and cause stroke. Inflammation from herpes, HIV can also affect the brain arteries. But I won't discuss this. I'll discuss this often forgotten stroke risk factors, from acute and chronic infections that causing inflammation can cause acute stroke by making atherosclerosis more quick and altering the coagulation pathways and atherogenesis. So I, for acute infection. Having an infection raises a stroke risk. In the first week of any infection, the risk of stroke goes up by 4.6 times, especially if there's fever, there's respiratory, and a bacteria like pneumococcus, H. influenzae. These infections of the lung can raise the stroke risk by 4 to 6 times. What type of stroke becomes more frequent is atherothrombotic stroke, 5.7 times, and cardioembolic stroke by 3 times. So acute infection, especially respiratory, bacterial, can increase the risk of ischemic stroke. Other infections too. For example, influenza also raises stroke risk. How does influenza and other infections raise the risk of stroke? Well, we think it's because of induction of procoagulant states, like making more fibrinogen or destabilizing plaques that are already there. So these are the mechanisms by which infection can cause stroke. Interestingly, if they stay in hospital for too long, being in hospital also raises the risk of stroke. So being in hospital is not a good thing for many people, unfortunately. Can we prevent stroke from infection? Those who have no infection yet, does giving antibiotics help? Unfortunately, no. Many randomized trials of antibiotic therapy do not prevent cardiovascular points, including stroke. But there is something we recognize from this. Treating with a viral agent does make a difference. Treating influenza with an antiviral medication can reduce the risk of stroke by 28%. Vaccination can also reduce risk of stroke in a case control and a cohort study. In fact, in Taiwan, vaccinating people above 65 years old reduced mortality and stroke by nearly 65%. So treating influenza can prevent stroke. Vaccinating against influenza also prevents stroke. Here's a meta-analysis showing overall that vaccination can reduce stroke risk by up to 18% when you pool the results of all the trials. So clearly vaccinating can prevent influenza, can also prevent stroke. I is for acute infection, I also for chronic infection. A few chronic infections, CMV, herpes simplex, gum infection, chlamydia pneumoniae, H. pylori, the stomach, and other infections. All these infections raise the inflammatory burden. And together with other host factors, hypertension, diabetes, cholesterol, smoking, other risk factors, raise the risk of atherosclerotic stroke. So it is believed that all this, by promoting atherosclerosis, raise the risk of stroke in people who have any of these chronic infections. Individually, it doesn't seem to make a big difference. But when you combine them together, the inflammatory burden increases by 1.39 times if there is chronic infection. So having chronic infection in combination especially raises the risk of stroke, even though you adjust for age, gender, education, and other risk factors. So chronic infection alone can reduce stroke risk, not just acute, but also chronic infection. One example is chlamydia, the best studied. In this, whether IgG for chlamydia is high or IgA, overall the risk of stroke is increased by about 1.6 times or up to 2.3 times. The strongest association is with atherothrombotic stroke, not cardiomyopathic, not lacuna, but atherothrombotic stroke. The next I is for inflammation. I for acute infection, I for chronic infection, I for inflammation. Inflammatory mechanisms have a big part to play in starting and progressing atherosclerosis. So this is not due just to hypertension, diabetes, cholesterol, and smoking. Inflammation can also cause atherosclerosis and make it worse. Inflammation can make a plaque rupture, can cause clots to form, embolize, and cause stroke. Too much reactive oxygen species can cause endothelial dysfunction and increase stroke risk. Inflammation itself can raise the prothrombotic factors. So these are various ways by which acute and chronic inflammation lead to stroke. A number of markers of inflammation, CRP, fibrinogen, amyloid A, LPA2, interleukin-6, and so many others. Some of these are available in many labs routinely. Overall, CRP increased the risk of mortality, but not stroke individually. Ischemic stroke, no big difference, as you can see, in control versus inflammation. Heart attack, yes, a higher risk. When a sub-analysis was done, CRP was associated with cardioembolic stroke. So possibly high CRP, which is chronic inflammation, causes myocardial infarction that then leads to cardioembolic stroke. And that is how CRP is probably linked with ischemic stroke by causing more cardioembolism. Can we prevent stroke in those of high inflammatory burden? Let me share the Jupiter trial. In the Jupiter trial was a randomized trial of statin versus placebo using rosuvastatin. in those who had no coronary artery disease, who had normal cholesterol levels, but high CRP. The study found that that they could, by giving Crestor, they could reduce cardiovascular endpoints, including stroke, by up to 48% by giving statin to those at high CRP levels. So what do the guidelines say? The guidelines say that from this information, that giving vaccination can reduce the risk of stroke in those who have stroke, who don't have stroke yet. And treating influenza can reduce risk of stroke also in those who have influenza. Measuring inflammatory markers may be useful to find out those at risk of stroke, though we don't know if it should be done for everybody. But for those who have high CRP and no other stroke risk factor, maybe giving a statin can reduce the risk of stroke. However, giving antibiotics is not recommended to reduce the risk of stroke in individuals. So we discussed the I, acute infection, chronic infection, and inflammation. Let me move now to the U factor. What is the U factor all about? The U factor is unhealthy air, air pollution. So much we're seeing of air pollution now in many parts of the world. Air pollution occurs when harmful or excessive amount of substances, be it gases, small particles, or molecules, enter the atmosphere. These particles cause many diseases, cause allergies, and even death. Not just to humans, but to other things. Animals die. Our pet dogs, our pet birds, our pet cats, our cows, and all are dying from stroke. And the crops we plant, rice, all die from pollution as well. And this pollution damages the natural environment we live in, the forests, our lakes, and damages our buildings. So pollution really does a lot of bad things. But it's true that pollution can occur naturally and also by things which we do. We ourselves can create air pollution. What are natural things? Volcanoes erupt, forest fires occur. There also are thunderstorms. These produce natural pollutants. But sadly, we humans also make pollutants by burning our fires and burning our crop areas, incinerating rubbish, our cars and trucks and aeroplanes, our factories, burning our fuel, using things like aircon refrigerants, metals. All these are polluting the air. So these are primary pollutants. When these pollutants mix with particles like ozone and smog, they cause further pollution. So primary and secondary pollution are all bad. And the pollutants could be small particles or could be gases. Whatever they are all bad news for stroke. Look at the size of particles. They can be big. They're called the PM10 particles. They're up to 10 micrometers. They're soil, things from the dust, construction work, industry. Could be fine particles called the PM2.5, which come from burning our petrol, from power plants, and from heating the homes and other places. Then the very, very fine particles, the ultra-fine nanoparticles that come from our vehicles, especially from diesel. All these are particles that are bad for health. If you look at this meta-analysis, where there's pollution, there is stroke. So air pollution and stroke are very strongly linked in these countries, and the data is very clear about this. Which particles are important? Carbon monoxide overall, yes, especially in the early phases after exposure. Sulfur dioxide, yes, again, in the early phase. Nitrous oxide, yes, again in the early phase. Ozone, probably not. But look at the small particles, PM2.5, early phase and forevermore. So these particles hang in the air for a long time and raise the risk of stroke. So overall, while the strongest association is on the day of exposure, there's also long-term risk from the small particles like PM2.5. So short-term exposure, yes. For some, also long-term exposure is also dangerous. Particles can raise the risk of lung infection, the risk of cancer, the risk of COPD. There's also risk of heart attack and stroke. Among the young, especially among age 25, also middle-aged like you and me, and among the elderly like our parents and grandparents. All of these raise the risk of stroke, both especially 2.5 PM and also 10 by these factors. So clearly particles on the long term, over many, many years, raise the risk of stroke. Up to 25 years, the risk of stroke remains. These small particles do not go away. They are there, they enter the body and cause the risk of stroke and heart disease, and of course, lung diseases. How do these particles raise the risk of stroke? One, they cause a systemic vascular stress reaction, and that damages blood vessels. Oxygen radicals are produced, damage endothelium, activate monocytes and other atherogenic processes that cause plaques to form. Thrombus may form, and so can coagulation and platelet factors. Finally, blood flow is affected, and all these factors raise the risk of stroke from acute and chronic pollution. So what can we do? We've got to stop the pollution. I see this picture of the Taj Mahal, beautiful when there's no pollution, horrible when there is. I'm sure there are many parts of Vietnam that may be affected by pollution too. We must stop the pollution to prevent stroke if best we can. I've discussed I've discussed you. Let's now discuss the X factor, relevant to doctors, nurses, therapists. This X factor is about you. What is this? Working for long hours. Because of pandemic, I know you all don't sleep. You're working from morning to night, and this is not good for you. In this meta-analysis of more than 500,000 men and women who have no stroke, they were followed for 7.2 years. If standard hours are, say, 8 hours a day, 40 hours a week, you work from, say, 8 to 5. That's 8 hours a day for 5 days a week. That's normal. If you work more or work less, is it dangerous? Well, here are the studies. They've shown as you work longer hours, the risk of stroke goes up in all the various studies. But here's a nice meta-analysis in the next slide. You'll see here that those who work for normal hours or less or more, there's no effect on the heart. But look at the effect on stroke. So all of you, please pay attention. If you stay in the office, work 9 to 5, you're okay. You work less, probably okay. But if you work for 11 hours a day, 5 days a week, the risk of stroke goes up by 33%. So long hours are not good for you. Every one categorized of stroke raise a risk by 10%. So if you work 11 hours a day, you're going to have the risk of stroke of 33% more than those who work from 8 to 5. So what to do? What can cause this? They believe that this can occur from sudden death because you're working so hard, your stress goes up, and this can cause stroke. Also, we work so hard with no time to exercise, no time to eat properly, drink too much alcohol, smoke too much. All this raises risk of stroke. Also, we work so hard, we ignore our transient weakness. We ignore our slurred speech. We ignore double diplopia. We take a longer time to go to hospital to seek treatment. Although we are doctors and nurses, we should know better. We do all these things because we work so hard and we raise our risk of stroke. So what can we do? Please don't work so hard. So therefore, Professor Hung, ladies, gentlemen, stroke is a major cause of death and disability throughout the world, and Vietnam is no exception. There are many well-known risk factors: age, getting older, being male, all that we know. Known risk factors, hypertension, diabetes, cholesterol, all we know. But don't forget the emerging ones, including acute and chronic infection, chronic inflammation, air pollution, and long hours. And these emerging factors must be considered because we now have good treatment for this. We must now address this. But one message to you is please don't work so hard. Please go and rest much as you can to prevent your stroke. With that, I thank you. Thank you very much.
Xin
Thank you so much, Dr. Ramani, and very impressed for this report. Because you about the breakfast for course, easy to remember and forget. I want to add the host now the COVID-19 pandemic. Dr. Ramani research on the correlation between this COVID-19 and the faster talk as well about vaccine. Thank you.
Thank you very much. I may have missed the question. What's the question again for me, please? So sorry.
The host now, the COVID-19 pandemic.
Yes.
Your research on the correlation between this
correlation between COVID and infection and stroke.
Oh, yes. Thank you. So important. Yes, you're right. I'm sorry I didn't hear it clearly. My connection is not very good. My fault. Yes, COVID does increase the risk of stroke. It is well known. There are some mechanisms. It somehow causes a procoagulant state or inflammation of vessels and causes large artery thrombosis. So many young people are having large artery occlusion with no obvious cause. It was thought to be cardioembolic, but it may be more than that. So you're right that COVID does raise the risk of stroke, especially large artery occlusions. Okay. In fact, vaccination may also risk the risk of stroke as well. There's also a small risk. But overall, vaccinating against COVID has a more benefit than causing the risk of stroke. In those who have a stroke before and who don't take a vaccine, they have a higher risk of having a worse stroke the next time around. So even those with stroke are also encouraged to take the vaccine. So those on aspirin and other blood thinners, we say take the vaccine and press for a longer time to prevent bleeding at the injection site. So you're totally right. I agree with you completely. COVID raises the risk of stroke. Those who have a stroke, don't take the vaccine, have a higher risk of worse stroke next time they come. So they must take the vaccine to reduce the risk of COVID. Thirdly, we know that vaccine can raise risk of stroke, but the raise of risk is small. Benefit much more than risk. So please, everybody must take the vaccine. Thank you so much.
Xin bổ sung thêm một ý kiến của bác sĩ Minh Đức nữa. Câu hỏi cũng rất là hay là chúng ta trong cái hội nghị thần kinh thế giới vừa rồi ở Rome đó, thì một cái bà giáo sư ở Milan á, là người đã chứng kiến rất nhiều cái đột quỵ liên quan đến Covid. Thì bà cũng nói rằng một trong những cái nguyên nhân mà bệnh đột quỵ tăng vọt ở Italia là một nước thu nhập cao ở bên Âu Châu, là chính là nhiều người bị đột quỵ đã bị bỏ quên, bởi vì cả thành phố miền Bắc nước Ý đó đã tập trung vào để điều trị cho Covid, và những người đột quỵ gọi những cái xe hồng trật tự không đến. Điều đó có nghĩa là cái sự không được đến cái nơi điều trị đúng của những bệnh nhân mới bị đột quỵ cấp cũng có thể là một trong những cái yếu tố làm cho cái tỷ lệ bệnh đột quỵ và những diễn tiến của bệnh đột quỵ xấu hơn. Thì I will just put a little bit comment about the COVID infection and stroke, because as in one speaker in Rome, she consider that the number of stroke patients, they don't have the access to the stroke unit during the COVID time. It's increasing. So that the healthcare, Italian healthcare abandon them. and the number of severe stroke patients and the number of death is increased during the COVID time because of the lack of healthcare system to them during the acute phase. This is a big issue, and I think that for some developing country, just like Vietnam and Cambodia and maybe Malaysia and Singapore, maybe not. Yeah, and India, India.
Yes,
Your native country. Yeah,
yes.
that happens. That happens.
Yes.
Okay.
I agree entirely with you. People are too scared to go to hospital, even though they have stroke, they're afraid they get COVID from somebody else. So number of admissions for stroke have fallen in many countries. If they come late, so they can't get TPA and thrombectomy and stroke unit care. So I agree with you, Professor Hung. I agree completely with you. It's very challenging in developing countries. Singapore's lucky, but well, plus and minus for everything. I really hope the pandemic will settle soon and we can continue to take care of our patients the best we can. Thank you so much.
Mảng đột quỵ này là một cái mảng rất là đặc biệt, là vì chúng tôi nói gì thì nói, thì đột quỵ vẫn là một cái ngành lớn trong thần kinh với bệnh tim mạch. Bây giờ các đồng nghiệp, các anh chị em có câu hỏi gì không ạ? Bởi vì chúng ta sẽ chỉ còn một ít phút nữa thôi là chấm dứt.
I have a small question about the COVID.
Tiến sĩ Toàn.
COVID and COVID we can see is a new risk factor for stroke. The question is, do we have some preventions in case patients with COVID for prevent the stroke in the future? Because now we see COVID-19 is a risk factor for stroke, and how we can prevent it. Thank you.
Okay. Thank you very much for your nice question. Right now, they don't recommend giving a blood thinner to prevent stroke in those with COVID. Right now, they don't yet, because we have no trials to show the benefit in those who have not had a stroke yet despite COVID. So generally, we treat the COVID the way that it is and treat all the risk factors in COVID patients. So be even more strict: no smoking, blood pressure, diabetes, cholesterol, look for atrial fibrillation. So treat all the risk factors even more strictly. So I agree with you that those who have COVID have a higher stroke risk, but I don't think we can give a prevention medicine to prevent stroke in future. But I think treat the risk factors very aggressively. That's the current recommendation. Why are we cautious? Because there are unproven treatments right now. Also, there's a bleeding risk among the elderly. Many elderly have a high risk of having COVID or having worse COVID. They also have a high risk of bleeding from aspirin. And therefore, overall, maybe it's not yet safe to give aspirin prophylactically. Studies already show among the healthy people, giving aspirin increases bleeding risk already. Imagine elderly. So maybe not yet, but maybe a trial can be done to see if giving aspirin or some other blood thinner can prevent stroke risk in future. Until then, among COVID patients, I think just treat the risk factors best we can until we have better evidence. I think so. Or maybe you have some experience to share, sir?
Yes, thank you. Thank you for your answers. I am pleased with your opinion, but do you think the treatment anticoagulants in COVID, SARS-CoV-2 positive can prevent the stroke events in the future?
Yes.
Yes,
you're right. Well, anticoagulants are used in very severe COVID patients. That is true. Yeah, prevent DVT and all that. Whether we can use it as a primary prevention for stroke is still uncertain. Certainly, they're giving it to prevent other thrombotic factors, venous and other thrombosis. So I think they're giving it to prevent systemic thrombosis as opposed to preventing only stroke. So I think it's being given. But right now, the data to say prevent stroke only is probably not yet strong. But I must agree, in severe COVID, they need to prevent other thrombotic at lung and elsewhere. So maybe in that setting, it might be for severe COVID. For mild COVID, I think probably not, because the risks may outweigh the benefits.
Tức là Giờ chúng ta hiểu
Okay.
rồi phải không ạ? Không thể nào mà đem phòng ngừa chống huyết khối mà cho tất cả Covid, mà chứ cái bệnh nhân mà nặng đó, bệnh nhân mà có nguy cơ tử vong, mà những bệnh nhân có biến chứng nhiều, vì thế này cái tỷ lệ đột quỵ trên bệnh nhân Covid cũng đâu có phải là cao lắm, chúng ta thấy không? Bây giờ chúng ta phải chú ý cái vấn đề phòng ngừa nguyên phát và phòng ngừa thiếu phát. Và chúng ta thấy rõ là gì, là cái đột quỵ này 2 ngày hôm qua có nhiều vấn đề rất là mới. Cái thứ nhất là gì, chúng ta dùng trở lại cerebrolizine. Cái đó là tôi rất là thấy là có một cái ý nghĩa, tại vì cái đây hồi tôi năm 1992 khi tôi làm nghiên cứu sinh ở chợ rẫy lầu 9, cô Minh Đức biết đó, thì chúng ta cũng không thương gì cerebrolizine lắm, nhưng bây giờ cerebrolizine lại được thân thương, trở nên rất là thân thương. Thứ hai nữa là gì, là những cái chúng ta rất là hân hoan và chúng ta rất là nồng nhiệt với lại những kỹ thuật can thiệp như là thrombectomy này, rồi cho những động mạch lớn này, hay là những cái như là NTPA. Và chúng ta lại được giáo sư Ramani nhắc nhở là những yếu tố nguy cơ là những cái cơ bản và chữa được, phòng ngừa đơn giản mà lại hiệu quả và lại có thể áp dụng được, nhất là các nước đang phát triển. Chúng ta ô nhiễm, chúng ta sợ ngồi thức đêm, tôi cũng thức cả đến 10 tiếng một ngày, tôi ngủ có 2-3 tiếng một ngày nhiều khi như vậy. Thì tôi là người gọi là rất là sợ khi nói vậy là cái gì. Chúng ta thấy rõ là chúng ta kiểm soát yếu tố nguy cơ rất là quan trọng, và cái đó chúng ta trở về là tại sao cái dịch thứ tư, làn sóng thứ tư của Covid ở Việt Nam lại có vẻ tăng lên, vì chúng ta là gì, chúng ta đã quên mất cái vấn đề y học cơ bản phòng ngừa tại cơ sở. Và bây giờ chúng ta thấy rõ chưa, 3 cái chân, 3 pillar for stroke cực kỳ quan trọng: stroke prevention, new treatment and lifestyle. Nhớ
Yes.
mà. Okay, so that I just resume the issue related to stroke. Okay, thank you so much, Professor Ramani.
Thank you.
I appreciate it. Vâng, chúng tôi cảm ơn giáo sư Ramani rất nhiều, và hẹn gặp lại giáo sư Ramani trong 2 năm sau tại tỉnh Cần Thơ nha.